Good afternoon. Okay, we have a good. Okay, you have a good lunch. I hope everybody is doing well after the storms. So I heard a lot of stories around. So I hope everybody, your families are doing okay first. So we're sorry about our beautiful city, town. So I hope we can get together again and be okay. Okay, so today want to be a little special meeting. I want to talk a little bit of everything about uh, the new oncomings and something that was planning for that last year, but it's reality now. We have new medications in Parkinson's. There is a lot of research. So I, we have to be very proud. One of the people that more research, Dr. Hauser in Tampa, and he was participating in one of the new medications that you will be getting, and some of you already trying. Crexon is one of the big news. We have another medication which is a pump. Uh, it's not the pump that you think is the one to go to the stomach. It's one to go to your skin. Actually, there's two of those, and actually that one that is already in place and approved. So let me go start with this. That's okay. We have a special sound effect right here. That's okay. That's so that keeps us awake. Thank you for that. No worries. Let me see. Mine is yeah. I pay you back. No, mine is valid. Okay, so we start with the history. Initially, we talking about medications, and we always are waiting for the cure of Parkinson's. So back in the day, there was a miracle drug that was levodopa, and after getting several attempts to get there, then we had that is like today the standard of care. But in 1969, levodopa was given initially. We know dopamine or the dopamine is not going to go to the brain, so they start with a drug or a component that going to convert in the brain to dopamine, which is the one we use every day. And after taking the dopamine by itself, the dopamine that the God can give you nausea. So the nausea, finally they get the combo. They place a carbidopa to avoid the nausea. Now we have the medication that we well know as Cinemed. Cinemed from the Latin sin, without, and emet, that the way in medical terms, emesis is vomiting. So without vomiting. Back in the day, you look at the movies when this medication start, people they getting the medication and get to the toilet to throw up. But now, even though many people are you experience now shaving with a combination, sometimes we can give you an extra levodopa, it's called lodocin, to avoid the nausea. But let's see, that was a miracle medication back in 1969. I was about only 8 years old by then, not anymore. I get into the sixth and seventh floor already, so welcome. Okay, so that's the thing we talk about news, and you look on internet, you say last month and here, and then when you go to appointments, somebody go to the paper, I read this in internet. You know about this study, right? So it's thousands of research. So is you go to a particular one, it's very difficult to me to answer. They said, and they look at me, oh, you don't get up to date. But I want to show you how much is going on. So that's Cinemed, right? So many of you recognize that is our yellow pill and pill pill that are used for dopamine challenge. Many of you experience that. I had to stay the whole day or the whole morning to do this. And this pill is very important because for us, I can see the improvement in front of my eyes in the same day. And it's called dopamine challenge. Sometimes we confuse that you don't have or you don't get a good result with dopamine because could be sometimes be intolerance. Sometimes we got different formulations. Sometimes people get disappointed, get the immediate release. Then with the continued release and finally the extended release. So let me see, I'll show you different versions of this. So dopamine is what is lacking in the brain in somebody with Parkinson's. We're going to talk a little more later about the physiopathology, basically the alpha-synuclein. The alpha-synuclein is a misfold protein, and we are a little behind with Alzheimer's. And Alzheimer's, which is another misfold protein, the beta amyloid, we have treatments and it's going now. We have infusions in the clinic, very proud to have the memory clinic, but Parkinson's is going the same path. So I want to show you some studies that have been showing. And again, I get a good presentation that you will see in the end. I want to show you something like people say, I have this, I have that. And finally, we have to get some studies. So it's possible this presentation is a little long, but around 2 p.m. we can start. It's up to you guys, so we can go part 2. So most likely we need to do part 2. So I want to go slow with this one. So after the carbidopa-levodopa, the Sinemet, then we had the Sinemet CR, continued release, which has been used still and used many times. You have the immediate release, and sometimes you don't do well. We do the standard release at night. You have to remember, people say, why I had to take the medication at night? I at night, so why? So it's because you have a big gap. I have somebody to takes the last dose at 5 and the next day they get at 8. So you see, will be a gap like more than 12 hours. So what happened is the medication start wearing off even at night. So you want to sleep well, you start difficulty turning in bed, they can have more urinary frequency. So it's very important to have this level up at night, or in the morning. You have no wonder you have freezing, not able to move, because the medication is not in your system, it's out, right? So dopamine is like the gas for your car. Is you don't place the gas in your car, how you want to move it? Or it's like I have somebody today, unfortunately, have deep brain stimulation. They didn't come to me in 3 years and the battery dies. So guess what? DBS will not work. So let's continue with this. So then we for the continued release with extended release. So this is a little bit of how you say continuous versus extended release. So continuous release is the one we have, but really the extended release is the new generations of the carbidopa-levodopa. So talking about the extended release, then we have Rytary. Rytary, many of you use it. It's like you have cell phone 1, 2, you have the 15 now. So we get an update in the same carbidopa-levodopa. So back in the day, in the awakening, you're using levodopa, now Rytary, and now I was mentioned to you, Dr. Hauser participate in a study. Now Rytary will be replaced for the new, which is Crexont. So let's meet Dr. Hauser here. He will talk to you. When he was talking about this video, there was a research, but now it's a reality, and this has less than a month that we have this already. I have samples.
Parkinson's disease is a progressive neurodegenerative disorder in which patients are losing dopamine.
You know the guy, this Dr. Hauser.
As dopamine goes low, they experience the symptoms of Parkinson's disease, which include slowness, stiffness, and tremor. Levodopa is the most effective medication for the treatment of Parkinson's disease. But in its most common formulation, immediate release carbidopa-levodopa, it has a short half-life. Patients can go on it initially and it'll last dose to dose, but over time patients find that it only lasts a few hours. So they can take it, but it lasts a few hours and then wears off, and patients find they have a return of Parkinson's symptoms. We'd like to have medications that can be applied that will improve symptoms throughout the day. In an initial analysis, IPX203 provided more good on-time per dose. It provided about 1.6 hours more benefit per dose compared to immediate-release carbidopa-levodopa. These results...
Sorry, Dr. Hauser, I want to stop you right there. So basically, what there was in the investigation, basically was they saying Rytary, they give it and usually with this medication and research, they give you like letter numbers. So there was a research, but now is they place the name Crexont. So basically, he's telling me, or tell us, we have an actually national-wide meeting, movement disorder specialists around the United States, and he was one of the hot. He got in the research, and we are pleased to have Crexont. So basically, at least 1.5 hours more on time. And we're looking with the Crexont, the difference with Rytary is decrease the frequency and actually the burden of pills. So usually you go to immediate release to switch to Rytary, from immediate release to Crexont. You taking less than 500 milligrams of carbidopa-levodopa, we can give you 280 milligrams of Crexont twice a day. So only twice a day. Look, instead of 3 times daily. And I will follow with you. And again, if that doesn't work, we can go up to 3. And the advantage of this medication, and different with Rytary, this is given twice, 3 times, but no more than 4 times daily. So that's very easy, right? So you take it in the morning, you go for the day, and then you get home, you take the second dose, and you do. So as well for compliance is very good, because otherwise, many of you every 2 hours, on my meal, I something. You choose, okay, after my breakfast, or I take a bit of breakfast, and you're done for the day. You got your dinner, say, okay, you want to take another one, and that's it. So I don't want to, sorry, Dr. Hauser, they can see you in the next. I want to go to here, I want to close this. So he will talk about this, and that's Crexont. I don't know what those names coming from. Hopefully they said it will be approved by insurance. But first of all, before you are in the immediate release, extended release, Rytary, or any of those, we can probably consider doing Crexont. If the current Rytary is not working or you have significant wearing off, we can consider doing that. Before going to anything about the insurance, definitely I like to try with you. They are very generous, because there's some medication expensive, but very generous to giving samples. So before I got to all the Chavano pre-authorization, I want to show this good. Because I have in my back of my mind, I have this thinking about what happened, like the same with Rytary. In 75% of people, Rytary works. But you think about it, you're emptying or your belly or your gut is slow, and a person is a turtle and one is slow. It is slower, will be a problem. But the difference with Crexont is as well they have immediate release. So you want to see in the next picture right here how the complex of this. So it's a technology that actually have immediate release and have a novel technology to optimize the absorption. And there is the way that the medication adheres to the area absorption. That this is the component, is the miracle, the pharmacokinetics of this is the mucoadhesive polymer. So that make it the absorption and the delivery of the system more. And you see here in the tablet of the capsule, there are different colors. So there will be that component, but as well immediate release and extended release. So it's it's the same carbidopa-levodopa, but it's just the technology, all the components, how they make studies, and finally, we have the hope that we can use better. This roller coaster, you go like this, you go a small roller coaster. So that's Crexont. And many of you using as well in Inbrija, we have the spray, right? So that's something. Before we have Parcopa. Parcopa was something you dissolve under the tongue, but now for some reason, I don't know why, they took it out of the market. So, but now we have Inbrija. Inbrija is a powder. It's not like inhaler. It's not the same that you're taking for allergies or having asthma. It's something that is designed for you to have a small tip and they stay in your mouth. It's just to break down freezing episodes and work like that. The principle is the same when you have an issue with your heart, you have a pain or heart pain, you just place something like coronary disease, you place it under your tongue, and the medication goes straight to the bloodstream and work fast. The issue with this one, it will be work very nicely. I don't use it for dopamine challenge because I don't know how soon or how you want to react with your blood pressure. But I already know you and I have an issue, we can do samples on this. And actually with this medication, I can see the change in facial expression like this. And I can see the movement, I can see the tremor getting much better. Again, it should be price, but it's a combination, and it's carbidopa-levodopa. So looking about studies before, we're talking about initially was ABB 951, but now as previously research now is here, and it's called BLF. I don't know, again, these names, BLF. What is BLF? This system is a pump, and is for Parkinson's disease. It's a transcutaneous term. It's not the duodopa. Remember, don't confuse with infusion. There's one they go to a PAC2 that was in the past. That was for people very progressive, but there is two systems to go to the skin. This in particular that's approved already is for the skin in your belly, but there's another one, and actually somebody that is taken in the deltoid area. So this is a pump and seeing continued infusion of carbidopa levodopa. And that look like that. So you have the pump, you charge that like back in the day, we have a big cell phones that look like similar to that, the pump connected to you, and that's the thing. So there is all is about dopamine. There are some different names, and that's called Neuroderm. So will be soon in the market. We'll see if they pass the FDA. Okay, so trials to watch in Parkinson's disease. So I just want to tell you on the different articles, but I'm going to go to a full presentation. But this is, again, like you asked me for a specific trial. There is a lot. So we're very pleased that it's there, but I think we are a little behind. And the reason to be a little behind with Alzheimer's is because we are the second more frequent after Alzheimer's. Alzheimer's is very common and and of course, produce a lot of disability, cost-wise, and it's very devastating disease. So we have a hope. And so far, we don't see like immediate benefit with Leqembi or Kisunla, the two medications for Alzheimer's, but we haven't. I'm doing every day now. Initially, we were very concerned that going to be a bleed or something like that, as we're looking at. The same with, hopefully we can say the same for Parkinson's disease. But it's the same way we do TPA. TPA is a medication we use for a stroke. So initially we're very concerned about bleeding, but if you don't do it, people will be disabled. So you have to place risks and benefits always. And we have the way to monitor, so that's the future. We are behind, but hopefully we're going to go there, but I'm going to show some studies about that. Okay, so we went to this one, we went to this one. Okay, so there is some studies about the drugs that work inhibiting the production of neurotoxins. So we go to the root now of the problem of Parkinson's. Back in the day, and I want to go in another slides, I very proud to go from Georgetown. My mentor, Dr. Fernando Pagan, was working in a medication for cancer with Tasigna, actually for leukemias. Back in the day, it has been like 8 years. I want to show you in a study. But now that's the new thing. Not only go for the inflammatory process, we have to the root of the problem. And that's in research, that's not what the future is. So you see this Prasinezumab, all these antibodies, anything that going in phase 2 or phase 3. I want to show you a little more what different labs are trying to go the same steps that we're doing for Alzheimer's disease. So this is the synuclein. So that's the target. The target is the misfold protein in Parkinson's, the alpha-synuclein, that at the end of the day produce the Lewy bodies. The Lewy bodies you hear or you associate only with Lewy body dementia, but that's not the only thing. In the future, we are thinking that the Lewy body or Parkinson's have a new names, like Parkinson's with the Lewy body motor syndrome. People having autonomic disorder only, Lewy body with autonomic dysfunction, or people having MSAs or have any other conditions associated with Lewy body. So Lewy body is just the congregation of alpha-synuclein, which is a misfold protein that produces the disease. And we'll see. You want to see another slide, what is first? Is the body or is the brain first? We'll see. But I think we see first the gut and then the brain, but we'll see in this. So there is some limitations. We always look for the motor symptoms of Parkinson's, looking for off times, looking for cognition and fatigue. And so there is a lot of research on this. This is just in the news, but I want to show you in the next slides what we have. So we have studies for motor fluctuations. So you have the tavapadone, which is a medication that is going to go or target the dopamine. We got the receptors of dopamine, D1, D2, but in this case, D1 and D5. Okay, so basically, we have a lot, the same we have with carbidopa, we have a new generations for dopamine agonists, combination with ML, combinations with as well COM inhibitors. So that's we're trying to play around, but let me show you what's in research, what's in the bucket. Another thing I'm thinking about diabetes, and people now trying to decrease weight, and you know about Ozempic, Mounjaro, but again, they're doing studies as well in Parkinson's. So I will show you about this, and looking about how the metabolism, how you produce the insulin, and how they can potentially be effective in Parkinson's. So this is the situation in the community with Parkinson's disease around the globe. So I take this presentation that again is 2023, and I will give some updates about that in 2024. But I found this very instructive, and I will tell you where it's before. That was 1 year ago, but now something in reality, as I already showed you. So we're looking for new symptoms to treat Parkinson's. This is what the pipeline. So we know what's the current state of treatment Parkinson's. I'll show you about carbidopa, but early Parkinson's disease, and somebody showed me just recently a list. So what of these medication is better for me? So it depends. If you are in the early stage of Parkinson's, we talk about tremors, we talk about gait. Somebody yesterday came to see me for deep brain stimulation, on hoping that we help the balance. Unfortunately, it's not. The deep brain stimulation helps or works as good as dopamine. So the standard of care is Sinemet. If you don't get better with Sinemet, be candidate for deep brain stimulation. So in the past, deep brain stimulation in France, they use a different targets, and they try to target one area of the brain. Is called the PPN, or the parapontine nucleus. And they are pioneers to this, and they do multi-targeting, go to the STN and the subthalamic nucleus, and that for balance, but unfortunately has not been effective. So from early Parkinson's, and we want to now we start to see exercise, and along the way exercise. We do MAO-B inhibitors. So somebody asked me what medication I want to use. If I start seeing you just move, you have to create some swing, and you scoring Parkinson's is low, we do an MAO-B inhibitors. Now we have a lot of experimental treatments to slow the progression. Talking about the MAO-B inhibitors, we were in my fellowship, we tried to do a trial with Azilect or Resagiline to show slow the progression, but unfortunately that failed to show to be neuroprotective. But in the studies, but I'm very sure in the clinic it is neuroprotective, or at least I can say it is modifying the disease, and that's why I treated for many of you with Azilect or Resagiline. Many of you use Selagine, but again, the only thing that definitely I can say is neuroprotective nowadays is exercise. So many people ask about genetic studies, and somebody today asked me about genetic studies. If my father had Parkinson's, what's there for me to have Parkinson's genetic studies? For the most part, and I always say this, is idiopathic. Idiopathic, that means we're idiots. We don't know what's the reason. 85% of the cases. When it's secondary vascular Parkinson, like Muhammad Ali, and there is some genetic, and we're going to talk about that, and actually there's some target in a treatment for some genes, some gene therapy. But again, in the Jewish community, the LRK2, there is the GAP2, and P1, P17. So there is some genes, but usually John onset Parkinson's, you are more convinced are hereditary. So you are 40, 25, 18. I have somebody 18 years old with a dopamine deficit. I had to look very closely in the genes. But you come to the typical history, 60, 70 or some 76, probably not want to ask you to have a genetic testing, but still you convinced you need to do it for your kids, then you have to pay your pocket. But I tell you, insurance will not cover that. Okay, so they always said the Parkinson's disease is about 1 million people. I think we are more than that in the United States, and about 10 million. So we are like 10% of all the population in Parkinson's worldwide. So let me tell you about medications that have been in a study, and you can see that. So dopamine precursors, carbidopa, levodopa, So we go from extended release, continuous release, Rytary, Duodopa, and now Crexont. And there's more studies. Always like you have your cell phone, iPhone 15, they will offer you the 20 and then the 21 and this. So in the future, we get the combination and improve the way to deliver carbidopa, levodopa. MEB inhibitors, the one we love the most, personally loved, and I was a national speaker for a long time for recycling or Acylate now is generic. The price has no change, but the medication is still, I consider, a miracle. When I was in my residency, I called the vitamin A for Acylate. No, it's not vitamin. It's because make it look better, people with Parkinson's. Look, a vitamin is to keep you coming to life. That's the name of vitamin. Selegin is as well an MLB inhibitor. It's okay, but sometimes insurance don't approve recycling, but I think it's like 10 times less potent, but still it could be very good. And there is a new one, it's called Xadago. There's a sulfonamide. I got samples like 7 years ago. I never used that, but again, it's MLB. I just buy it. And usually medicine, you have to stick with one medication that work good for you. For example, a muscle relaxant, I like Flexeril, I stuck with that one because I know the side effects that work fine. I will stay with that, try to do something else. But definitely for me, I graduated in 2008, I'm using this medication, and most of the time it's not prove me wrong. Usually it's very good. From dopamine agonists, apomorphine, it sounds like morphine like narcotic, but it's not. It's not a narcotic. It's a dopamine agonist. They have been in studies because the way the delivery has been very difficult. Some of you remember back in the day, Apoquin. Apoquin was an injection, produced a lot of nausea. Recently, because of that, they want to try something delivered better. There was a sublingual. Unfortunately, they had to take it out of the market because there was financially was no good, because with that, we need a medication for nausea, and we used to use Tigan. Tigan was an medication for nausea, and that was taken out of the market. So I think that took that medication away. And they're trying to do actually other ways to deliver apomorphine like infusion. And so the apomorphine is very good for freezing episodes. So we're going to be freezing the injection and get on time. Pramipexole has been there for a very long time. And again, always want to improve that. And you see there's more studies about that. Pramipexole in my book is, because somebody asked me about medication, Pramipexole in my book is the best medication we have available for tremors. It's the most effective. Better than ropinirole, Pramipexole, and all this group can produce impulse disorder. I have people coming from Washington, D.C., coming to the Indian reserves just to gamble. That sounds funny, but it happens. Impulse disorder like gambling or hypersexuality, people going in the internet or going and buy things. So that can happen with this. And as well, hallucinations. There's the Pramipexole ER. Unfortunately, the limitation nowadays about this medication usually is the insurance. And again, it's still, they're trying to do more work in this and more research. But the problem with usually the standard release Pramipexole, which the brand name is Mirapex, like Miracle, Mirapex, is usually insurance don't cover those. Usually Pramipexole, just plain, that usually works. The ropinirole, many of you that have Rayleigh syndrome, they know that works as well for that, but as well the extended release or Requip, and we have the Nupropatch or Rotigotine, and unfortunately, again, that's very expensive. And again, they try to do a combination with these medications. I just remind you what the medication we have and what in the next slides, what they do in the combinations with this. The common inhibitors, we have entacapone. The combination between entacapone and carbidopa levodopa, the name is Sinemet without vomiting. Now, levodopa, in order for you to stay in levodopa, you add entacapone, so the name of the brand name is Esta Levo, stay in levodopa. So that's the combo, carbidopa, levodopa, and entacapone. But now as tolcapone and there's opicapone. So there is new generations. Now we have a new medication that is actually only once a day. The entacapone is supposed to be 3 times daily, but this is definitely more expensive. And actually, the same manufacturer now of Crexont and Rytary get this new medication. So amantadine is a very old medication that we're using before for a cold, and it happens that we people have in the pandemia, previous pandemia, a cold, they got amantadine and they just be happen to have Parkinson's, not only get better with the cold, but with Parkinson's. So this medication have been now, it's an old medication, but have been evolving or progressing, and now it's called Gocovri. Gocovri is an extended release amantadine, and I found not only good for dyskinesias, but I found many people having a typical Parkinson with dystonia. For dystonia, it's very good, and as well, it's improving the on time. And before there was an issue with hallucination, not as much with the recovery, but give you more on time. So for dystonia, dyskinesias, more on time, and amantadine as well, they're supposed to improve the gait and sometimes give you more energy. So people having fatigue, amantadine is one to give. And as well, amantadine has been as well used in conditions that are no Parkinson's. People with fatigue sometimes use amantadine. Anticholinetics, I'm not very pro of the anticholinetics, but sometimes you need to use it like Artane, Cogentin. More in the drug-induced Parkinsonism, I use it, but not much of the Parkinson's. Why? Because the cognitive part, side effects and cognition. Okay, so you see here what's the options for Parkinson's. So the first line, levodopa, right? So levodopa is the standard of care. Is the one is what is missing, so it's like the gas for the car. Then the MAO inhibitors, we just talked about the recycling, and somebody was asking me what's my favorite option. Again, we had to go in another slides. We need to individualize treatment. It's not like a treatment is going to fit everybody. And then we have the common inhibitors. We just talked entacapone, or Oxentis is the new once a day. The dopamine agonists, we just mentioned about starting from Mirapex, Requib, and Nupropatch. The anticholinetics, again, are very old, and finally, amantadine. So no pharmacological therapy is what we do here. The education, exercise, so this is the place to be. Exercise, physical therapy, speech therapy, or as well, we have to look at nutrition, all the supporting services we have here, and finally DBS and focus ultrasound. So in the clinic, one of my residents, Dr. Goyard, is right there. Thank you for coming. So we talked this morning about DBS. You see somebody that the DBS was not working, so for sure you could not see the effect of DBS. But the reason for me to be a movement disorder specialist, I love deep brain stimulation. In the right indication, can improve your quality of life. People have very significant tremors, not improving with medication, or have a lot of motor fluctuation. DBS is a good option. But remember, going to the DBS is like you go through a traffic light. It would be green, and some point get yellow, right? You say, no, I want to do it. And they get ready. Say, no, I want to. No, it's not. It's not for you anymore. Because that could be cognition or medical issues, or medical illnesses probably will complicate the things. But cognition had to be intact to have DBS. The focus ultrasound, we don't have too many here. In Tampa, Boca Raton, Miami, Celebration. We had not too many experience. Again, in Europe was first, but again, I explained to Dr. Goyal this morning that this is an ablation. It's something irreversible. We don't do it here, but first of all, you have to take your hair away, and they place a frame, they place you in an MRI, and the MRI guided, and it's not like you want to take a sub and that's it. No, it's just in and out, in and out. It could be several hours, and after you can see your tremors better. But again, if you have any good hands, it's good. But remember, it's irreversible. Okay. So this is the way we start the natural history of Parkinson's, and we had to do different treatments. And in research, we're not going to only for the motor, we have to look for from the beginning, starting with constipation. So there were several studies, actually, we participated on a study for constipation. Down, we have an issue with the sleep. Then you have problem with your depression or issue with the sense of smell. So actually, one of the studies want to prevent or to diagnose early Parkinson's, then doing studies of looking for your sense of smell. So you have family that is concerned or have constipation, they can start testing that. And I want to show you a link where you can have some screening testing for the beginning of Parkinson's. We don't have it here, but there is a link that you can do on your cell phone. And then it depends on the stage. There are different treatments now, but there's a lot ongoing in research in any of this stage. Any single symptom of Parkinson's, including cognition, many things have been lines of research. So you ask me for one specific research will be a lot. There is a lot. I will show you in a second how many are. So what we do well. So that's what we do well, treatment for motor symptoms. So tremors, we have several options, and even though some people don't get it better with tremors, but it's not because the medication is not work. Sometimes it's because you don't have the true Parkinson's, but the Parkinsonism. We have a treatment for dyskinesias. So we're decreasing the amount of the medication or give amantadine. A treatment for medications wearing off. So we're trying entacapone, we can the Inbrija, and treatment with no motor symptoms. So orthostatic hypotension, we have some medications from Florinef, midodrine, and specific in Parkinson's, Northera. For depression, multiple SSRIs, and we always have help with psychology, psychiatrist. But depression is not only medication. It's what you do every day, exercise, you have a routine, you have a support, psychotherapy. So it's not only medication. Hallucinations, we have to go the opposite. So it's like you give dopamine to improve Parkinson's, but you give too much, you can produce hallucinations. Or if I give amantadine for dyskinesias, I can give hallucinations. But you start from the beginning for hallucination, not many symptoms of Parkinson's, Lewy body dementia, then we have Nuplazid. So we have a very good medications. So where are the gaps? So we need to see for the freezing episodes. So the freezing episodes, I told you about the apomorphine that we're getting. Again, the Kainovi was the thing that was dissolving that unfortunately they take it away. But there is some new research in combination with that and dopamine agonists. I will show you in a little bit. So treatment for no motor symptoms. So always we forget, upon intending, about cognition, right? So we said, okay, we never talk about that until this. Okay, I know this is a problem. So at some point, we had to talk about cognition. But talking about cognition and the MLB inhibitors, we have a research at Georgetown. We did a study for MLB inhibitors and cognition, and we see how Aselect, and that's another reason why I give Aselect, can improve 1 point in your cognitive score. For sleep and fatigue and many other symptoms, there is a lot of lines for research. So let's continue with this. Okay, here you are. So this is for every single indication. You see how much lines of research are. So please ask me one and tell you, look at this graph, and you can say good luck and look at the national, on the NIH. And again, Dr. Hauser is very well known in the area for research. We have some research here, but there is a lot. In University of Florida in Gainesville, they have a lot of research, and they have people who specialize in MSA as well. So there is a lot of research that you can get. Okay, so what's the new horizon? Again, that was a presentation from last year. Definitely there is more now, and there's something that was before now is a reality. So in that, they were thinking there was a research for a infusion with AV, so it's already here. I already show you. Apomorphine infusion as well is in the works. So we'll see in the process to be submitted to the FDA, probably it's already there. So hopefully we can hear soon about this. That was last year, so this year we haven't had that. So we have another ones like I was telling you, a combination of pramipexole with recycling. So combination to improve the tremors and as well to improve the progression. And then when I told you the pramipexole is one of the best medications for tremors. So you only have tremors and your Parkinson's is very in the beginning. We can use an MLB inhibitor and pramipexole together, and that seems to be much better. So the study is going to tell us about this. Okay, so as well, we talked about that there was as well in research last year, but it's a reality now about the Crexont. That's the one that's a very version of Rytary. Okay, so we have another ones that is a D1 and D5 agonist. So we'll see that's in dopamine agonist as well. So we'll see how that works, how the side effects. That for the motor. Now for the non-motor symptoms, we have a lot of cognitive problems in Parkinson's. So the NDN the receptor, we usually use something like Namenda, but there's another component is called Aptinex, which is in the same, probably the same group on Namenda that's for cognitive in Parkinson's. There is as well another agonist, it's called Anavex, that's in phase 2, probably more probably phase 3 now. So that's an area that we need a lot to improve. But again, many people with alpha-synuclein could be as well beta amyloid problems. So sometimes we need a PET scan. We need to know it's one or both sometimes, unfortunately. So what are missing? We need treatment to slow down the progression. So now the way to slow down the progression is exercise. Exercise and exercise. I'll repeat again. I'm going to get tired pounding to say exercise. Because the only thing is neuroprogressive, is neuroprotective, but I only say, please do it slowly. I don't want to hear that you injure your knee or you have an Achilles tendinitis, because there will be a big bump in the road. Because trying to make you better, that will be much worse. Then you need to heal for 6 weeks without doing exercise, and your decline is very fast. Okay, so let's see what is neuroprotective. So can you see that very small graph right here? Is all the studies that are right here. That was last year. So you see this year will be even worse. So this is the list of hope. These are all the list of studies that actually they did a very nice review what's going on in there. And you see by years how many studies. So back the year that was more prolific was in 2019. And now I think after that, 2019 sounds familiar. COVID-19, after that gone down. You see, with the COVID, definitely many research went down, as you know. This guy, look at here, you see my picture I look like my grandson. The person in the wall look at my grandson. I aged like 10 years, so that happens. So this is the main actor of the movie today. This is how you get Parkinson. This is the alpha-synuclein. You can meet the Lewy body. So Lewy body, and what happens, how this is going to progress and damage your brain. This is the way that goes. This is the microtubule. So how the alpha-synuclein can produce toxic in your brain. So the way I explain for these toxics or these misfold proteins is, I said, an example is like, I always take the trash outside of my house on Tuesdays and Thursdays we come on Fridays. So just imagine they don't come on Tuesday. So I don't want to leave the thing outside. So I place it in my garage. And then the sun didn't come, so I had to place it again in my garage. And then all the trash is accumulated, and finally it's going to go in my living room and I'll be killed. So that's a toxic. So these misfold proteins are toxic. Or your body tries to accumulate and place it like in a small plastic bag. Is when the alpha-synuclein is the Lewy body. So the Lewy body stays there and depends what organ start producing the damage, the symptoms you will have. And it will progress. You remember back in the day, about 2 or 3 years ago, there was a lot about the prion. That was a prion disease. That means full protein, prion for protein, and ion infection. So there was a theory that actually Parkinson's was a prion disease, and probably it is. So if we talking in a previous talk, it is, you see like a root of a tree. The way you feed it is the soil. So the soil, the way we feed is our stomach. So usually that prion is starting in the stomach. You have the constipation, and then ascending to in your nervous system, and then you get to the nucleus of the vagus, and then you have constipation, and then you go to the locus coeruleus, and then you go to the substantia nigra, and then with that, in the midbrain, you start having tremors, and finally you go to all the bushes, which is, I'm not talking about my hair, I'm talking about the brain, So that gets the cognition. It's the natural history of Parkinson's. It starts with constipation, and later in Parkinson's, you have cognitive problems. You can have dementia, hallucinations in Parkinson's late state. But if you come from the brain first, one that hit your brain, have hallucinations, that's Lewy dementia, is the different way the alpha-synuclein can attack patients. So this is the studies that we're going for alpha-synuclein targeting. So again, we are a little behind in relation with Alzheimer's disease because we're in the second place, how frequent it's happening. But hopefully, with all the studies that you see there, we can go something similar to have the memory clinic now. We can talk about infusions in the future. So you see here, so they're different. The Roche program and the Biogen, they're working in that. They're saying they work and they have approved medication on Alzheimer's hopefully soon or in the future. I don't know how soon because we're talking about neurodegenerative disease usually takes years and years to approve. So the first time in medicine, actually, we can make the diagnosis almost 100% of Alzheimer's. We have the beta amyloid PET scan, and if we make that the same with Parkinson's, and then hopefully we can target the alpha-synuclein in Parkinson's. So this is the studies that showing and promising that hopefully in the near future, I don't know, it could be near future, we can relatively be months, could be still years, to get medications for the same that is before wasn't in the news for Alzheimer's. Now there was a trial, now it's reality. And so hopefully not only the memory clinic, but the Parkinson's clinic or infusion. We have in our center in Intercoastal, we receiving referrals to people be treated with Alzheimer's disease. And they have to be in early Alzheimer's. If you have a very advanced Alzheimer's, will not happen. And even people with mild cognitive impairment, we have an screen. And in the future, not the same with Parkinson's. We want to have a blood test. Now it will be some for Alzheimer's. Even now, we consider normal, what's normal. So the beta amyloid accumulates for 15 years. Probably we can say something the same for the alpha-synuclein. So hopefully in the future we can say, okay, let's do a test. Let me see, I have my alpha-synuclein. Let me test it. Okay, I have it. Okay, give me an appointment with Dr. Marple, the oncologist. I want the infusion and I want to read it out. And then hopefully we can, before you have the symptoms of Parkinson's, you have family history to read of that. And that's will be the future for Parkinson's and Alzheimer's. Okay, so now many of you seen, okay, many people say struggle, I need to decrease weight. In Parkinson's, most people with Parkinson's, the opposite. Actually, we struggle with low weight, we talk about that. But in more of our people with no Parkinson's, actually it's obesity, and they are usually working with Ozempic or any of these medications for diabetes. And why? It sounds that definitely as well some promising as well, not only for Parkinson's, but with cognition. So there is some insulin resistant signaling that can go to the brain and can produce some problems of toxicity, and that way can produce Parkinson's. There are different ways people have been working with the inflammation. People work with alpha-synuclein, and even people have working with medication for cancer to try in that way we can attack Parkinson's or find the cure. So far, we don't have the cure, but there's a lot of studies there. So many people actually use this Ozempic or Mounjaro to decrease weight, but this promising hopefully for cognition and even for Parkinson's, we'll see. So that's research going on. So we have to target as well cell energy pathways, the GLP-1. That's the way these medications work to decrease weight and for diabetes. And you see many people decreasing weight and mild diabetes. And in that way, you control diabetes as well. You probably have protect yourself against cognition, and many people have some studies in cognition and this medication to improve cognition. So that's the mechanism. So you improve in the cell level, this oxidation of the energy, or this we can prevent to have a not only decrease weight, but decrease dementias or even Parkinson's. This was in the news, and that's why we refer to my mentor, Dr. Fernando Pagan. I want to point that out 1 second. I'm very proud. He's amazing doctor. He was the one that started the movement disorder program at Georgetown, and now I think we are at least 100 movement disorders and he's very young. Probably he's younger than myself. I remember I in the 6th floor, I'm a dentist myself. I went to the military. I came here to a scholarship in 1992 at the Rotary Club. I want to meet them next year, and I have to love to say hello to and thank you to the Rotary Club because they gave me the opportunity to be here. But in any case, nilotinib is a medication that we use for leukemia, and Dr. Pagan sent for a studies. And initially, when we had one of the meetings, we have a lot of hope. Unfortunately, since the study since no, but there was a lot in the news about this medication, and supposedly to be here. I want to see here Dr. Fernando Pagan right here. You see in the corner his name. He initially there was a secret. They want to do it. I want to be. Unfortunately, we are still waiting. There was a lot of hope, but I think that exam has been decreasing. But something is there, and this is the conclusion. Both doses of Tasigna were safe, but there was no evidence. So the only way we always prescribe something or we talk about medication is based in evidence. Many of you can ask me, doctor, look at this. I have this for memory. This is good. Or look at the magnesium, or look at this, or like CoQ10. You have to show me your evidence. If you don't show me evidence, I cannot endorse for. I can say you can take it, you can take it or not, but I don't have evidence. So unfortunately, this was so far with this conclusion of this, with this review, they said there is no, but again, still some studies going. I think they don't stop there. And there is a lot of studies or trials to try to find out there still is something there. Remember, sometimes the design of the length of the study is not enough to show, but still we have hope that something is going to be there. So you see all these the studies for that. So what's first? Is the brain or is the gut? So for the most part, we have the typical Parkinson. You start in the gut, the prion disease, and finally progress at the point in the late stage, you can get the Parkinson-associated dementia. But it hits you brain first, and you have hallucinations, and then you have the other symptoms later on. Is probably the theory for the Lewy body dementia. But the for most part is the gut first, prion disease. Okay, so as well, like 3 or 4 years ago, there was a lot about the good guys, the good flora in your stomach. And I promote my country always. Wake up and smell the Colombian coffee. The coffee and nicotine supposed to promote the good flora in your stomach. If something nicotine is good, and nicotine is a drug and it's a good drug. The problem is smoking, the fumes of the thing. But the nicotine as well is to have some clinical indications. So that promote the good flora. So we know there is some abnormal flora in your stomach can not protect you again. We're thinking that this protein go there, and if there is a good guy there to protect you, come over here. That's the good flora. When there is no good flora there, then it's more prone you to have Parkinson's disease. So we talk about that. We talk about Helicobacter pylori. We talk about by then 2 or 3 years ago how they can interfere with the absorption of the dopamine. So there's a lot in that. What about stem cells? It's something have been on and on and on and off and off. And there's some studies in California. There's a lot of things. And so many people come and ask me the same question. Unfortunately, we don't have this over here, but again, in the news is always there. So the theory is very good, but in the beginning, it's like you place stem cells and they have no control. It's like you place like a tumor, but it's in there getting there. There is some studies, and hopefully we can get there. But still, since I graduated, I looking about stem cells and Parkinson's, but still not. But still, there's a combination with gene therapy, placing in the virus, place some genes to can replicate dopamine in your brain. So there is a lot. But this lady here in California, they say she's getting, and she's probably having some novel stem cells, continues to show promise for Parkinson's disease. So you can look, and we have the hope. Hopefully, she has as many other people working with this. I know in Texas, Dr. Jankovic and other ones have this, but we don't have here. So the stem cells or restorative therapy, you see all the studies we have ongoing currently. So it's promising. Still, it's not the standard of care. It's nothing we can offer here. Many people ask for us, but again, we have to refer to another centers to have or offer this. So we have to work for, actually, I have been doing a good time. Probably want to finish the presentation today. I'm sorry, I speaking like usually in my clinic very fast. That's why they call me Speedy Gonzalez. That's my Mexican cousin. So the Parkinson's disease, we have the current medicine. You see, we're looking initially in somebody else. No, I think, and that's why many neurologists or neuro practitioners thinking that Parkinson's only one and there's one treatment for everybody, and that's not. We had to have more of the future medicine, and what we're trying to do is you are unique and your circumstances, and that's the way we have to treat you. So we had to do a tailored, we had to tailor your treatment, but in general terms, we had to look for exercise, gene therapy. Again, you asked me for genetics. The ones are two genes we're looking more is the GBA. They said that about 10% of people with Parkinson have that gene. You say we tell you 85%, and now have like other range secondary or products on genetics there. In the Jewish, I can see they have 1 or 3% sporadic populations with Parkinson's disease. So there are some trials targeting those genes in that population for the LRRK2. So many people come to us and ask, okay, do I have to get tested? And I just had this question just this morning. So she was asking me, so my mom had Parkinson's, so do I need to test for this? I said, okay, it's coming to the clinic. We don't have available. You can look around. First of all, you have to discuss with us, and I'm telling you right now, it's very important, but they will not be approved by insurance. So the main side effect with that will be a little pain here, around here, about your pocket. It will be very expensive. But again, it could be important. If you have a joint onset or has implications, genetic counseling is very important. So you can look for that. How I can get the genetic testing? So there is some programs available. So you have to the Parkinson Foundation, PD, gene. You go to and Google that, and you can see other places that can get you tested. So and right now the panel seems to be limited, and again, that's very important genetic counseling. So, are we ready to step into the Parkinson's prevention studies in any single step of the progression? So we are, again, there is a lot of studies. National Institute of Health, you want to look for the studies. Go to the University of Florida in Tampa or the UF as well in Gainesville. So there is some studies going and they are recruiting. That was a participating for Parkinson's. You have loss of sense of smell, then start doing a screening for that. There is an issue with sleep, and there is some possible genetic they're doing some. So you can look, you can participate in some studies. So you have to spread the word. We're getting some studies in our group. You can actually ask if we have any studies for that. There is no line for too much for Parkinson's. Again, the boom right now is for Alzheimer's, but we looking for the studies in Parkinson's. And then this is, if you have a problem with, you can actually take your cell phone or later on, you can actually, with the cell phone, you can see the queue that you can get the website where you can get how you can be screening for Parkinson's just with the decrease in sense of smell. That's a study. But again, if you have, we have a biopsy as well, the alpha-synuclein. If you happen to have a appendectomy or any other, the alpha-synuclein could be in any of your tissues, so they can be tested. So alpha-synuclein, there is a biopsy. We don't do it, but there's a way different places do it. What should we tell patients with Parkinson's disease? What I have to tell you. So you have to seek an expert opinion, especially for Parkinson's Disease Center. We have here in Tampa. We have again in Gainesville. Some people that are coming back and forth from the North area, Washington, D.C., and Georgetown, and then the Boston area, and New York, Columbia University. Inquire for a clinical trial. So in those places, you can go for clinical trials. What I have to tell you, do your exercise. Have a good, a positive outlook. So we have very good medications. There is a lot, and you ask me in one in particular, again, it depends on your circumstances. You give me a list. I had to see you and to see what your symptoms, and then you give me a list like that without examining you, I cannot tell you. So what should we tell patients in the interim? Meditation. So remember Hakuna Matata. Don't worry, be happy, enjoy your life. Every day has the stress, so enjoy the smile, and we are happy to be alive. Every day has their own stress. So try to you exercise, enjoy that, doing a diet. We usually recommend Mediterranean diet, and always feel the sense of well-being. That's the meds, not the medications, but meditation, exercise, diet, a sense of well-being. It's not only medications, it's meds as well. That's our sense for medication. So that's funded intended. So what I have to tell the patients, you have to move it or you lose it. You diet, you right here, that's where you do exercise. We promote the Tai Chi, we have boxing classes, a healthy style, positive attitude, because unfortunately, the more we age, we hit it for diseases. And that happened. We as a physician will have problems. I have, yesterday, my one appointment, and I was a little late, but I had to take care of myself, right? So the same thing, we are human beings. At some point, we have a problem as well. So we have to keep good attitude, right? This is a street of two ways. So keep that attitude. Give me a smile. That I'm trying to give you my smile. A smile is free, but you can smile to somebody. That is a lot. So that was this presentation was giving more for the Parkinson's disease therapeutics pipeline in March 8, 2003, but I updated with the thing ongoing. We do it here in the Parkinson's place. We appreciate the people that prepared that. But thank you very much. And yes, sir, your doctor. That's it. The Norians is a different pathway. So Norians is not the typical pathway, but unfortunately, Norians has been, I don't know, has been effective for a few people, but it's not. Thank you. I don't, for HIPAA, I cannot tell you, but you share with us, I appreciate it. So yes, Nurians is in a different pathway. So it's looking different out the box. So that's in a different pathway to improve the movement. So any other questions?
I have a question.
Yes, please go ahead.
I put my question in the chat area, so can you take a look?
I'm sorry, I could not. You had my same problem. Your speech. Do you mind to speak slower and repeat your question?
Okay, I have two questions I put in the chat room. The first one is Cinemed. They're made by different manufacturers. Sometimes when I get my prescription, it will have a light white color, sometimes yellow. I feel there the strength is a little bit different.
Yes. So when you're talking a generic, so again, usually we see the Cinemed, the generic carbidopa usually yellow, but come in different shapes. The color sometimes could be the strength is different. Usually, the dissolving one was blue. And then definitely when you have your prescription, be sure you get a different generic had to be the same strength. Again, remember, we are human beings. Sometimes we can make mistake in different ways. Myself, the nurse, the pharmacist. So be sure your prescription when it refill is adequate. And again, if we say one mistake, we have to excuse it, but that can happen. Just be sure you get and sometimes you get from one generic to another, it doesn't work the same. Why? I don't know, but that happens. That's supposed to work the same, but that happens.
Okay, thank you. And
no, thank you.
My second question is about Kristen. the dosage if like higher.
So your question is they can go a higher dose? That's what you asked me? You asked me we need to increase the dose, is what you're asking? So sometimes we need, I'm sorry, go ahead.
If your dosage is a little bit higher, will it result in you feel a little bit more dizzy?
Yeah, sometimes we need to increase the dose. Again, individual case, we have to do that, but that's in particular case. Again, I tell you how to tailor. No, sometimes increase dose or higher dose doesn't mean it's best, right? Sometimes because the medication is not lasting enough, or we just talk about you give you a higher dose, we can put you in a risk to have your blood pressure being low, or have dyskinesias, or have hallucinations. So how to be careful, always balance one thing to another. So that will be the answer. Again, with the new medications like Corexon, again, we go to the immediate release. And the beauty of this new medication, again, is not only increasing the dose, is making your life easier, and they give you a big range. It's less than 500. I give you less than 500 per day. I can give you 280 twice a day. You have more than 500, it's easier for me now. And from doing the Rytary before, it was very difficult. And now you have more complicated schedule with carbidopa every 2 hours. I had somebody come already 250, and somebody have one tablet every 2 hours or 3 hours. So that's more difficult. So definitely we have a hope that with the Crexon, it will make yours or my life easier. But again, we talk about Teleron. So you ask me a specific question, we have to look at the specific case.
Thank you.
My pleasure. Thank you. I don't know which one you talk about. There are different ones. There is a glove that is Stanford in California, and actually we presented one of these. And actually, when we had the last meeting in Neuro Challenge, one of the patients came with that, and we presented the video last time. I don't know the one you referred to. For essential tremor, there is another one. It's called Calatrio. I got that very disappointed, but the other one is not invasive. It's stimulation, and actually he claimed that the stimulation in your hands that actually can give you more dopamine, and actually they control your tremors. But coming on our devices, that when they control the tremors, the brain stimulation, the high frequency ultrasound, but I don't know other device. I don't know there's any or specific, have the name or any specific of the name?
We were recently introduced to it, and I lost it on my phone. While you were presenting yours, I was trying to and it was
like a yeah, probably the Calatrio, probably similar to that. I don't know. They're looking like in a watch. I know there's one of the brands Calatrio. I don't know exactly the same thing. We have to look the brand.
was involved in England.
I think one of you in previous presentations point to me about the globe. We talk about that. And there's a lot in Europe that usually have a little delay to come to us. But I know there is a version from the globe that is in England as well. But I had to look which one you are talking specific. Watch. That sounds like the Calatrio, but again, it could be a different brand. So we almost the same principle, try to give some stimulation to try to decrease the tremor. For tremor, there is another device, but it's not to decrease tremor, but it's improve quality of life. There is a device that if you tremor like this, just to use the spoon or something, you check right here, but the end will not shake. So the mechanism allows to the spoon to stay steady, even though you're moving, but this is getting steady, so you can eat. But Just for treatment of the tremors, again, we still very pleased with deep brain stimulation. For all the Calo-3, other ones had to look the specific, but again, we don't have too many here. I don't know for FDA approved, we have to look up. Actually, it could be the new topic, but look for more of those if there is something else. And you can give me the name, we'll look at that. Yes, so it's probably could be the same. I have to look a little more. I'm not familiar with that particular one, but most likely could be the same principle. But let me look at that.